I'm Dr. James Amos. I'm a staff psychiatrist at University Hospital in Iowa City. And today I've got a short presentation on the process known as maintenance of licensure, which is very similar to maintenance of certification. And the question I'm going to try to address is, should maintenance of licensure, or MOL for short, be a condition of medical licensure in Iowa? And this is a hotly debated topic in medicine and psychiatry these days. So I have a dozen slides here, as I usually do, and I will have annotations and a discussion with the slides on my website, thepracticalpsychosomaticist.com, and I'd encourage you to go there and read the full presentation. The slide that I'll start with is entitled, "Should MOL be a condition of medical licensure in Iowa?" And I want to point out that I agree in principle with what MOL and maintenance of certification, or MOC, is all about. And that's the principle of the importance of pursuing the goal of systematic continuous professional development of physicians. I have always agreed with that. I don't agree that MOL or MOC help me do that. And I'll try to outline the reasons why they don't in the ensuing slides. I believe it would be a mistake to make participation in MOC as the main criterion for substantial compliance with MOL. One reason for that is that thousands of physicians oppose MOC. It's a very controversial and time-consuming and very expensive process. And there's no high-level data yet showing that it improves outcomes. That's not to say that there's no data, but there's no high-level data. Now, the Iowa Board of Medicine has undertaken maintenance of licensure, or MOL, implementation pilot projects, and I've included the link on the slide to help you review that. I have formalized my opposition to maintenance of licensure with a petition and a resolution against MOL in Iowa that I presented originally to the Iowa Medical Society House of Delegates on April 20th, 2013. The Iowa Psychiatric Society has co-sponsored the resolution, and the reference committee discussed the resolution at the IMS House of Delegates meeting on April 20th, 2013, and adopted the resolution with minor changes on April 21st, 2013, with no opposition. So the resolution, as amended, reads this way: Resolved, that the Iowa Medical Society supports the continued lifelong learning by physicians and the improvement to quality of practice, opposes the institution of maintenance of licensure for those who are board certified and or maintaining relevant CME and peer-reviewed quality of practice and or participating in maintenance of certification, and opposes further maintenance of licensure for all other physicians without sufficient supportive data demonstrating that the maintenance of licensure supports patient outcomes and improves quality of care. Now, that's my bottom line, really, about maintenance of licensure, and I introduced it early because I was supposed to present this to the Iowa Board of Medicine at a recent meeting, but I was on duty as the only consulting psychiatrist in an 800-bed hospital, and I did not have time to present it. So I was only going to be given 5 minutes anyway, and so I'm going to take this opportunity to give a presentation that gives me a little bit more time, but it will have to be short. So why does the maintenance of licensure exist? Why MOL? The safety argument is made quite a bit by many board executives and the FSMB, and I've included the link to that. And one of the origins of the safety argument, the idea is to improve quality of patient care and to improve safety of medical care. And it arises from high-profile safety failure cases like that reported by the Bristol Inquiry. Now, the Bristol Royal Infirmary Inquiry was undertaken by the National Health Service in the United Kingdom to investigate the deaths of 29 babies who had heart surgery at the Bristol Royal Infirmary in the late 1980s and early 1990s, and I've included a link to the story about that. It uncovered a lax approach at that time to patient safety, secrecy about physicians' performance, and a lack of accountability, much of which has improved over the last several years. Now, the Bristol Inquiry led to the United Kingdom to implement a system for physicians called revalidation, which is very similar to MOL. Now, the safety argument is only one of many arguments for supporting implementation of MOL. The FSMB also has a list of articles that purportedly show research supporting MOL, but it contains no high-level controlled studies. That doesn't mean that there's no data supporting MOL. It's not high level. The MOL components, and I think that's another point that we should talk about a little bit briefly to improve the understanding, especially by the public, about why maintenance of licensure is being promulgated. What are the core components of MOL? The framework for MOL, adopted by the FSMB House of Delegates in 2010, recommends that state medical boards require physicians to periodically demonstrate participation in 3 components of effective lifelong learning in medicine, all of which I support. Reflective self-assessment, assessment of knowledge and skills, and performance in practice. Now, according to the FSMB, if doctors are already doing MOC, they would be in substantial compliance with MOL. And so, again, the main argument here is that MOL would be duplicative and therefore unnecessary, which the Iowa Medical Society House of Delegates agreed with. The next slide is about the MOL Guiding Principles promulgated by the FSMB, and there are 5 of them, and I answer each one of them. And in the interest of time of this presentation, I'm going to ask that you read them on your own, because they tend to detract from the importance of pursuing MOL in the state of Iowa, and I would think in any other state. So the MOL debate really closely tracks the debate about MOC, or maintenance of certification. The MOL implementation debate starts with the FSMB promulgating MOL in 11 states, including Iowa, Ohio, Wisconsin, California, Colorado, Delaware, Massachusetts, Mississippi, Virginia, Oregon, and Oklahoma. The MOL project was defeated in Ohio in October of 2012. Excuse me. The North Carolina Medical Society House of Delegates resolution opposed MOL in 2012, and North Carolina was not even one of the original 11 states targeted for implementation of the pilot projects. The Medical Society of the State of New York House of Delegates adopted a resolution opposing both MOC and MOL in April of 2013. Now, that should say something to the public and to physicians and credentialing bodies across this country, which is that a process, whether you call it the MOC or the MOL, which is so hotly debated and controversial, probably should not be being pursued across the country as a condition of medical licensure. There are some other web links here for you to learn more about the MOC and the MOL. It's also important to point out that the MOC is so controversial that the Association of American Physicians and Surgeons has taken the American Board of Medical Specialties to court in a lawsuit filed in federal court on April 23, 2013 about the MOC interfering with patient care. The next slide is about my own professional development program, which I think shows that I'm heartily in favor of continuous improvement. I'm a consulting psychiatrist at an academic medical center. I attend and or present at CME activities. I supervise medical students and resident physicians on our General Hospital Psychiatry Consult Service, and I use clinical case conferences and literature searches to ensure that I am providing safe and high quality medical and psychiatric care. I have made presentations on our University of Iowa Health Pro Network, which a couple of them are available for CME Category 1 credit, and I've co-edited a book as well on psychosomatic medicine. My personal experience with the MOC is relevant. Components of the MOC that tend to be the most controversial and the most difficult to implement for physicians are in the performance and practice realm, or the performance and practice module, if you will. The department, many academic departments have a departmentally approved peer review system that purports to meet both Joint Commission and MOC requirements. These forms are never returned to me, and I therefore say that they're not going to meet ABPN or American Board of Psychiatry and Neurology MOC requirements. If I don't get them back, I can't use them. Now, I have personally solicited peer feedback in keeping with the ABPN MOC requirement. Patient feedback is also challenging and a little problematic in that there is always going to be a tendency to cherry pick. These patient feedback forms are something that the ABPN requires physicians to personally solicit. And I think that it would be more meaningful if they were solicited not by me personally to avoid cherry picking, but solicited by a clerk in my department. They're time consuming. That's another reason why they should be done in another way. The ABPN also does not want to see the actual feedback. Many of my patients are delirious or otherwise brain injured, making their feedback probably unreliable. Clinical modules are time consuming, and I also already frequently conduct literature searches in my work as a consulting psychiatrist. There is not an activity yet available for the most common problem consultation psychiatrists and internists encounter: assessment, prevention, and management of delirium. Yet there is a module for primary care physicians and psychiatrists about bipolar disorder. Now, don't get me wrong, I think this is an excellent module. It's free, it's easy to navigate, and it provides CME credit. It's called the NOW Coalition for Bipolar Disorder, and I've included a link for that. The NOW Coalition product, however, tends to underemphasize the low prevalence of bipolar disorder in the general hospital and in primary care clinics. And it recommends screening, though the likelihood is probably higher than anyone thinks that non-psychiatrists and psychiatrists alike will use the screen as a case-finding tool rather than a screen which exacerbates the tendency to overdiagnose the disorder. A product for assessment and prevention of delirium would be much more relevant to all medical and psychiatric hospitalists, important for enhancing patient safety and patient care quality, but it's not yet available. It makes it harder for hospitalists to comply with the PIP clinical module. The other point I want to make is that the 2011 American Psychiatric Association election referendum, critical of the MOC PIP feedback requirement, in which 80% of voters supported the referendum, failed to pass only because 25% of the members voted rather than the 40% needed. The referendum actually garnered a higher percentage of votes than any of the candidates then running for office. That should tell you something. The other slides that are left just document my compliance with credentialing as required by the Iowa Board of Medicine and the American Board of Psychiatry and Neurology, as well as my hospital. In the last slide contains some important web links, and I really appreciate your listening to this. It's not the usual type of presentation I do on my website, but I think it's critically important for both patients and physicians to review. I've never had a patient ask me whether I'm board certified or not. I think it's important for me to be board certified. I also think it's very important for me to keep up my skills and my knowledge base. But I don't think the MOC or the MOL is necessary for that.